Hello, this is Fernando Gomez Sancha, and I'm going to present a case of a patient who underwent REZUM treatment without success, and he was complaining of recurrent infections. And as you can see, there was a cavity apically near the sphincter, and probably that was the reason for his recurrent infections. So he came to us asking for a solution. He was happy to let go of the ejaculation. He wanted to get rid of the febrile infections that he was having. So I recommended him to have a HoLEP. And again, I think this video will show how nice the En-bloc approach is for redo cases, and just another proof of the versatility of this procedure. Of course, failed treatments can happen with any option for BPH treatment, and yeah, we see them after almost everything, including failed cases after HoLEP, because there was a complication or there was an incomplete removal of tissue. Well, these things can happen. And here, what I'm trying to do is I'm trying to delimitate the line of the white line at the apex. Sometimes in these cases, the anatomy is somewhat distorted, and well, you have to do your best to understand. But I have to say that when you do En-bloc HoLEP, which is always following more or less the same steps, it becomes easier and easier to treat these cases. Basically look for the reference of the interface between the adenoma and the capsule. You can see it there quite clearly, but of course, often we see that there's a more fibrous quality of the tissue. See, that's the cavity. This is the edge of the sphincter. So trying to mark the anterior part as well. So here, this would be the anterior part. And now the white line is connected, and this is a great reference. And everything you have to do after that is to go around the adenoma, trying to evaluate if the plane is correct. You have to go a little bit deeper, or if you're already going deeper and you have to correct your aiming so that you remain inside. My favorite cases are the redo cases. This is where I have more fun, because it's always a little bit of a challenge. Sometimes the effects of the previous treatment on the tissue are quite marked. Sometimes, the plane is not ideal. Sometimes you need to almost contact with the tissue in order to be able to cut through fibrous parts. But the solution for these problems are usually quite easy. This is the Quanta system laser with the pulse modulation at my current normal settings, which are 2 joules and 50 hertz. There you can see that sometimes the plane is not very clear. So you have to judge and do your best, and then at the end we'll have a look at and see if there's any bump or any residual tissue. But again, the circumferential nature of this incision, of this dissection line, is helping a lot, because you can see that it makes sense to go around like that and to follow the line. You can anticipate a little bit how the anatomy is going to be. Irrigation is excellent, visibility is excellent. The hemostasis provided by these lasers is more, it makes the procedure more comfortable. Of course, you can use a normal holmium laser, and but that will not have such a nice first pass coagulation effect. So you'll have to be more careful and probably go back to coagulate. My feeling with the normal classic holmium is that often the explosive nature of the laser will open up the vessels, and there must be some kind of spasm of some of the vessels. So initially, this spasm will avoid bleeding, but then after some minutes, these vessels will relax and bleeding will start. So you have to often review the surface you have treated. But here, as you can see, the chances of leaving uncoagulated tissues is a little bit less. So this gives you the advantage of a nice coagulation. So that's, again, the posterior aspect. We had a small discussion online. You see that I keep my fiber at 12 o'clock all the time, and I feel that gives me very good control. I don't have to be moving my hand, and it gives me precision in the sense that, as you can see, I'm firing often when the angle of dissection is changing. For example, here we are on top of the adenoma. I start pointing down a little bit with the fiber, because the angle is that way. And when I am below the adenoma, I have to be careful that I don't go through the retrotrigonal area. So what I do is I keep the targeting very close to the adenoma. That cuts the attachments of the adenoma with the capsule, but the energy is not going towards the capsule, so the risk of perforating is very low. And my bet is, when you have to move everything, your chances of pointing or targeting your laser correctly are a little bit less, maybe. So this is why I keep the fiber at 6 o'clock or at 12 o'clock, but I don't keep moving the fiber. I just use this position. You see that gives me excellent control and excellent simplicity as well. I like simple stuff, and I think maybe we can do ourselves. We can make our operations very complicated when there's no need. So here you see that's a small vessel near the bladder neck. Now we entered the bladder at 12 o'clock, and again I will try to do this circumferential dissection, trying to judge if the plane is good enough or if it's too deep. There's some fibrosity there. There's some, it's not a beautiful plane, but there are some hints. You always have to read the information you get in the screen. You have to be very vigilant to see the anatomical details that will tell you if you're doing the right thing. Here you see I am posteriorly working near the adenoma. You see my fiber is keeping close to the adenoma, so the capsule is receiving very little energy. It's just going to the adenoma and in a way that cuts the attachments of the capsule with the adenoma, so there is very little chance of going deep in this region. Sometimes we have to dissect very, very deep nodules, and the capsule is very, very thin, and we can manage those with this approach. So here you can see how the fiber is still anteriorly. I go around the adenoma, but you see the energy. So my point is the angle of incidence that you can get by rotating the fiber continuously. The modification in the angle of incidence is not so relevant. And to me, it's more relevant to be able to target your laser very precisely, either against the line of attack or a little bit inside. That's a small nodule, as you can see here or there. You always have to, guess you don't want to fire there. You want to fire a little bit more against the adenoma to see if we can cut these attachments without letting the energy go deeper. So that's it. So it's an ongoing discussion. And of course, we always learn from each other. And it's interesting to see what people think and have different opinions. But I'm quite convinced that this is a nice way to go because it is simple. You don't have to rotate the scope. You don't have to keep the camera. You just hold the instrument as you would hold a pistol. If you're going to fire a pistol, you fire keeping the bullet outlet at 12 o'clock. And this is more or less the idea. So here, you see it's always very careful. You don't need to rush it, but it will end very fast. You see that when you work in these beautiful visibility conditions, concentrating on where to target your laser, what distance from the tissue you want to fire. You find sometimes slightly more difficult angles or areas that make you sweat a little bit, and but if you are calm, you will get to the end of it. I think, because I don't exactly remember, I think this was a problem with the fiber, so I had to change it or something. I don't remember what happened during the procedure. So while I was waiting, I was just checking things out. There's just a little attachment on that side, on the bladder neck. That's the UO. And that's the cavity, verumontanum. And you can see the excellent preservation of the sphincter, which is what we try to achieve. Because, of course, as you know, incontinence after HoLEP, even when it's temporary, it's quite bothersome for the patient, and it's absolutely unnecessary to have incontinence after HoLEP. What I'm trying to say is that with what we know today, you can perform HoLEP without causing stress incontinence in the great majority of your patients. So it's actually a rare event, and when it happens, it's absolutely mild and tolerable, and the resolution is quite fast. So all this en-bloc enucleation technique and the early apical liberation and the white line and all these concepts, I think, are improving. As you can see, I am using a new fiber. I don't know what happened. It is quite unusual to have to change the fiber throughout the procedure, but obviously something happened. So there, again, you see, following the contour, following the line is a good idea. You can see that I move usually from, I don't do very small movements, but I try to do wide movements, you see, going all the way up. So the philosophy is to try to release maybe a little, but then take this little up and around, so that you can develop a nice circumferential line. And that's almost the end. You can see that we have a nice fossa, good hemostasis. There's some minimal attachment, but now the case is finished. Interesting, eh? I think REZUM has come quite hard as an option for treatment, and I think it is logical to see failed treatments because of poor patient selection, and sometimes maybe because of inexperience of the surgeons who are doing it. I think, as always, when one does a treatment very often, he learns, and the chances of problems are less and less. So just different options. What I feel sometimes is that the promise of ejaculation is quite obvious for any man. If you tell him you will ejaculate after the procedure, he will be happy. I mean, this is a no-brainer. You want that, but it's important to tell the patient as well that sometimes things can go wrong, and he might need alternative treatments. He might have complications, and it's important to have an honest discussion with patients. So, because in this particular case, the patient was a little bit sad that he chose that path, as things didn't work out well. I saw him recently. He's quite happy. His urinary symptoms improved a lot, and he didn't have further infections. And well, he was tolerating the anejaculation without much concern, as he told me. Yeah. So again, I hope you enjoyed this short case, and I will try to keep posting interesting cases as I get some time free to sit down and edit these videos. I'm getting very nice feedback from some of you who watch these videos, and I appreciate that. And yeah, as long as they are useful, I will continue to post. This is the morcellation phase. Again, trying to simplify. I use only one inflow, which works well for me with this equipment, but of course I am very vigilant. If morcellation is not very efficient, I'm very aware that I will be sucking out a lot of water, and then I stop and refill before I continue. With the piranha morcellation, morcellation is usually very fast, and it allows, I mean, even stopping a little bit to fill the bladder, it is a quite fast procedure, and I prefer that to having 2 inflows, which is a nuisance, 4 bags, 2 giving sets. And here, probably I was waiting a little bit. Sometimes the bladders are not so big, and they fill very fast, and they empty very fast. And that's the end of the procedure. I hope you enjoyed. All the best. Happy New Year.